Palisades Village virtually, and I'm Erica Blanton, the executive director here, and we are thrilled to have MaryAnn Griffin back talking about Medicare. She's done a whole series for us in the past on Medicare, and this is going to be a brief little synopsis to prepare us for open season. And I can't tell you what fabulous feedback that she got on the last series, and many people who thought it was just the best presentation ever on the subject. And she has the background to, which I don't know if everyone's read her bio, but she has a very impressive background in aging services, and we are thrilled to have you once again. MaryAnn Griffin, it's all yours.
Thank you. If we were on a runway, we would say, take it away, right? So I want to tell everyone that we are going to be sending the slides out after, because I know there's just a whole lot of information on here. And I'm Erica, I put it on speaker view and you're on there, not me. So what do we do about that to make me the speaker? Let me see. There we go. Okay. As I was saying, we're going to be sending the slides out afterwards because this is just sort of one of those jam-packed, filled talks with way too much information to be able to even assume you might be willing to write down. So let's get started here. And there we go. Okay. I want to begin this morning by just doing a brief frame of reference for Medicare, because I think, like most people, we don't necessarily, once you've enrolled in it, you sort of lose track of what the parts are. But the basic Medicare tenets, the platform on which everything else is based, is Part A, which is free. It's without premium, and it's hospital and home health, etc. Part B is the outpatient and physical therapy, physicians, etc. Part C is a Medicare Advantage plan, which is not part of a basic Medicare. And Part D is the only one that actually coincides with its assigned letter, and that's the drug plan. So I think to frame the rest of our discussion, which is Medicare mistakes, I want to just spend a few minutes on this. With Part A, it's the inpatient hospital, it's skilled nursing rehab, and it is any home health and hospice. I'm going to do one thing here, if you don't mind for a second. And could you tell me how to get the pictures off the side of the screen? Should I put a different view? It's blocking the slides. Can we do can I do something else or no?
Where did you want the slides, MaryAnn?
I can't see the whole slide because the pictures are all down the right-hand side. So how do I change that?
Let me check.
Okay.
If it makes any difference to you, I'm getting the full slide.
Okay.
Mm.
Okay. Well, then
Are you, Bob?
Sir,
Yeah. Yes,
you
I am. Yeah.
on your PowerPoint, is the view screen on the presentation? Start slideshow?
Yeah, we're there. Yeah.
Okay. Then it should be the full screen.
Okay. It's just me who can't see this full screen.
You got them memorized.
Basically, I have practically. Yeah. Geez. Ooh. Okay. Let me. There's all kinds of things popping up. So Part B is going to be a really critical piece to this, and that's one of the big mistakes that people make. So we will spend some time on that. But you know, as healthcare costs have increased, 80% is a huge chunk of money, and so Part B is a really important part. Supplemental plans, or the Medigap plans, they're not part of original Medicare. Those are sold by private companies, but they pay 20% of the Medicare premiums, the out-of-pocket cost that Medicare B doesn't pay for. And then there's the Medicare Advantage plans, which quite a few people have. And I don't know about most of you, but I've gotten so much mail over the last 2 weeks for every Medicare Advantage plan wants to sell me a plan. So we're going to spend a few minutes with that. And then the next, of course, is the Part D plan for prescription drugs. So let me see. There's a really weird box at the top of my screen that says live transcription, closed caption. Who can see this transcript? Can I turn that off?
Yes, you may. Just click the X.
Okay. Medicare has a number of enrollment periods, and these become important if you're considering making changes. So the very first one, the initial enrollment, is the month of your 65th birthday, and it's either 3 months before or 3 months after. There's a general enrollment period, which is sort of an enigma. It happens January 1st to March 31st. And then the annual open enrollment period is every year. It's October 15th to December 7th. And the special enrollment period, and this has become increasingly popular because this is after someone retires and no longer has employer coverage. And having literally had been in aging for feels like my adult life, I would say that over the past 5 years in the private practice that I have, I've had more and more people who are age 67, age 68, who are just retiring now, who didn't apply for Medicare up front. So this is the period that they would have in which to do that. Okay. There we go. Okay. So one of the first mistakes that people make is not signing up when they're first eligible. And sort of the thumbnail that everyone probably knows about is 3 months before your birthday, 3 months after your birthday, or the month of your birthday. What people don't realize is that literally the time it takes from the time you sign up until the time you get coverage can be as long as 3 months out if you don't sign up right on the month of your birthday. No one tells you that. So that's really important. So someone could have left their job in December, waited until January to apply, and they might be 3 months out from that before they actually get coverage. Medicare, however, has chosen to rectify this beginning January 1st. If you sign up on the month you're turning 65 or before that, you'll be able to have coverage on the next month. So some of you who've been on Medicare for a while will actually think mistake number 2 is comical, particularly when you're paying premiums. But I would tell you that there are so many people who don't realize that Medicare is not free. I do paid training for 2 organizations, and they have me come in like once, sometimes twice a year to work with their employees who are getting ready to retire, to have them kind of understand this whole thing. And people honestly feel because they've paid into Social Security and Medicare for all those years, they actually think it's free. And the fact that Part A is free is actually, it is probably one of the reasons that they think that the rest is free too. So people are actually quite shocked to learn that they have a premium for B, a premium for a Medigap, and a drug plan on top of that, and that the amount that they're going to pay for B is actually tied to the amount of money they make. So I think adding on to that out-of-pocket expenses like co-insurance and co-payments and things like that, it actually costs hundreds of dollars a month. And the bigger shock, equal shock, I guess, comes when you realize that basically they're paying substantially less this from their employer coverage. So all the above, I mean, people are, I've literally watched faces of intelligent professional people sitting there with, kind of like with their mouth open, being so shocked. So I want to call attention to this because this is so important and has so many consequences. We all know that Part B is really expensive and that the premiums are tied to a person's income. But if you don't sign up for B when you're first eligible to do that, you will pay a penalty of 10% for every year that you would have been eligible to do so, and you haven't done it. And basically, here's an example. 10% a month is a pretty substantial amount, especially given how expensive B is. But if somebody waited 2 years to sign up for Part B and they didn't qualify for one of those special enrollment periods that I mentioned, they will pay a 20% late fee for every 12-month period of time that they weren't enrolled. So the base premium, just FYI, the base premium for Medicare B this year has actually gone down. First time in recorded history, it is less than it used to be before. So for 2023, it'll be $164. They will pay a penalty of $32 a month. So instead of paying the base rate, they would be paying $197.88 a month because they didn't enroll when they were first eligible. So here's a chart, which is really hard to read, but it's the best I could do in terms of sort of screenshotting this. But based on the amount of income is how much your Part B will cost. So if you look on the left-hand column, people making less than $97,000, or the next column, if you filed jointly, making less than $194,000, you're going to pay the base rate of Medicare, which is $164.90. If you flip back over to the left-hand column again, if you fall in the 97,000 to 123, or jointly 194 to 246,000. In addition to your Medicare premium, you're going to pay what the government has called an income-related monthly adjustment amount, which is a surcharge, basically. It's a gotcha if I have ever seen one before. So these people in this tier, in addition to the $164.90, they're going to pay, based on their income, an extra, basically $66 a month. Well, when you wind down to the bottom of the chart and you look at the very last line, one might say that if you made $500,000 a year, what's the big deal? But the big deal is, if you look, people in that income range pay $560 a month just for Part B. It doesn't include any other pieces of this. So Medicare is absolutely more expensive for people than any employer coverage they have ever had, even if they have family coverage. So let me tell you, however, I learned this kind of in the very beginning when I started doing training, and it's probably, if anything, it's the best advice I promise you'll ever get. Because Part B is tied to your income, Social Security, which basically Social Security administers the Medicare program. And so what they do is they go back and they look 2 years ago at your modified adjusted gross income. Now, many people make less money in retirement than they did, not everybody, but they did when they were working. If that applies to you, or if you have lost a spouse and therefore your household income has gone down, or you're on disability and your income has gone down, there is a process whereby you can ask Social Security to take a look at your income and reevaluate the amount of your Part B premium. And that's basically called a life-changing event. That's how they designate it. And that's one of the reasons I'll be sending the slides out to you, because that's how you do it. But basically, they'll go in and they'll look at your income in real time, like today. And you can make this appeal. Now that we're sort of post-pandemic, probably will have to go in person. Pre-pandemic, you had to go in person. During the pandemic, they were allowing people to do it by mail, but taking a lot slower. So you make an appointment, and there's forms. You get the form, you print it out, you take it with you, you have the appointment made. But this makes, I mean, when you look back at this chart and this amount of money, and especially that next to the last column where it's the surcharge, if you can get your premium down, then by all means, take advantage of this. Let's talk for a few minutes about the Medicare Advantage plans, because they're very confusing. A lot of people get them. They're spending huge amounts of money on television ads for anyone who's seen, William Shatner or Joe Namath, who's a retired Pittsburgh Steelers fan or whatever. There's lots of money. And I don't know who among you at the New York Times, I don't, but there was a huge New York Times article Sunday about Medicare Advantage plans bilking Medicare. I haven't read it yet. I just got my neighbor's copy, but so they're in the news. So I think I'd like us to understand kind of the basis for the Medicare Advantage plans. They're really considered a one-stop shop for health and prescription drugs. So these Medicare Advantage plans, essentially, they take the place of a Medigap policy and a drug plan. So if you signed up for a Medicare Advantage plan, you'd still have A, you'd still have B, but you combine it and you basically let the plan manage your benefits for you. For example, let's say you went to get your COVID booster. You wouldn't have to show your Medicare card because B is generally Medicare B is where infusion drugs or anything that goes into your arm and not in your mouth or into your vein, those are all paid for under Medicare Part B. And you wouldn't have had to show your Part B card. What you show is your Medicare Advantage plan card. Now, these companies are offering all sorts of bells and whistles. They'll offer you a gym membership and home delivered meals if you are hospitalized. And so all those things are really pretty attractive to people. But the big takeaway in all of this is a Medicare Advantage plan, you have to continue to pay your Part B premium. Plus, you pay the premium for the plan. So essentially, you're paying, you still have A and B. Again, they're the platform upon which all of this is based. And then you're paying a plan premium, which could be less expensive than buying a Medigap plan and buying a drug plan. So these are these are considered hybrid. Medicare pays them basically to coordinate your care. And I think that's where some of the confusion comes in, because when people see, oh, they're managing my care, I don't need the rest of this. Well, indeed you do, because dropping your Medicare Part B when you enroll in a Medicare Advantage plan, which people actually do, is like disastrous, because to qualify for the Advantage plan, you need to have A and B. But I think what people see is people hear, oh, we'll manage your care. And a lot of them are premium free. You pay nothing. And so the assumption, and I don't think that this is my personal editorial comment. I don't think, given all the publicity that these have gotten, I don't think there's any one of the pieces of material that tells you that you still need to continue to pay for A and B. And I think that's extremely misleading. And it's there, I can't tell you how many people I've talked to, they said, oh, well, I didn't know I still needed that because I have a Medicare Advantage plan and they're managing all my care. So it doesn't mean a person is stupid. It probably, in my mind, means the Medicare Advantage plan didn't do its job. But if the consequences of dropping it are pretty dire. Number one, if you drop B, immediately your Medicare Advantage plan terminates. Then you have to wait to the next general enrollment period. And that's January 1st to March 31st. So any point in the year, you're still waiting. So the ding on all of this is, depending upon what month it is, you can reapply between January 1st and March 31st, assuming you recognize it before that happens. And then the new coverage isn't available until July 1st. So you think about what that means. Anytime during that period of time, if you have any kind of medical issues, the only coverage that you have is Part A. And then in addition to that, the other ding is that you end up having to pay that 10% late enrollment penalty for the Part B during the time that you weren't on the plan. So let's talk a little bit more about these, because one of the mistakes is not knowing the difference between the HMO and the PPO if you're looking at these plans for a possibility. And I should say this just as a caveat, I just happen to have a Medicare Advantage plan through United Healthcare personally. The only way I can have this plan is because I was a City of Alexandria employee, and they don't even offer this in DC. But it's really confusing for people. So an HMO means you have to stay in the network. It also means that for most things, you have to have a pre-authorization. It's really difficult to get a second opinion, and especially difficult if you want to go outside of the HMO organization. And if somebody spends time in North Carolina or California or Florida, anywhere, if your plan, and let's use Kaiser as an example. Kaiser is probably the most well-known of the HMO Medicare Advantage plans. And they're really big in California, and they're really big in the Pacific Northwest, and they have a pretty strong presence here in the Mid-Atlantic region. Well, if you have one of those kind of plans, and it's not just limited, but Kaiser's one that most people know. If you're vacationing in South Carolina, or you spend a couple months a year in Florida and you get sick, you're not going to have any coverage. So you might have emergency coverage, like you could go if you fell and fractured your hip or something, and you could be seen in the ER. But you're not going to get hospital coverage, and you're certainly not going to get primary care coverage because you're outside of that geographic area. So for anybody who travels, I'd say really think twice about this, even though the premiums are obviously a lot less expensive. So within the PPOs, they do have networks, but you don't have to stay in the network. You may pay a little bit more, but you've got the freedom to visit any doctor you want at all. And so even those premiums are going to be a little bit more expensive, but in general, they are, it gives you a lot more latitude. Doesn't matter where you are in the country, if you're traveling, if you've got a PPO, the chances are, even if it's not an in-network provider, your copay might be a little bit more expensive, but it's going to be a covered service. The HML model basically says they sign up in their network, doctors and nurse practitioners and healthcare professionals, and they negotiate rates. And I've had to actually, when I worked at Georgetown, I actually had to negotiate a couple of these. It's been 100 years ago that happened. But the interesting thing was the ones that were the easiest ones to work with was Kaiser, because they had it down to a science and they knew how much they would pay for services. But using Kaiser as an example, if you got sick and you go to Sibley, Kaiser would likely transfer you to one of their two hospitals where they provide the service. They have a wing at Suburban and they have a wing at Holy Cross. So let's say you had an emergency and you went to Georgetown or Sibley. The likelihood would be, if it were something that were going to be require an actual inpatient stay, they would transport you in at their expense from Sibley or Georgetown to either Holy Cross or Suburban, because neither Sibley nor Georgetown is likely to be in their network. I'm not sure about the wisdom of transferring, but nonetheless. And the thing that most people complain about is if they need a second opinion or they want a second opinion, that seeing specialists outside of the HMO network is almost impossible. It just won't get covered. So as we said, the PPO model gives you a lot more flexibility. You can continue to see who you want to see. And it's really a better choice, especially for people who do any kind of traveling at all. And I don't know about you, but most people I know who get a bad diagnosis, cancer diagnosis, don't want to take the first person's opinion. You know, they don't want to have the heart surgery just based upon one person's advice. And so to them, having a PPO model is really important because they can go see somebody else and get the second opinion. I did a little non-scientific study when I actually did a course, I think it was for Palisades Village a little while back on Medicare Advantage plans versus straight Medicare. And I did a little study just also based upon the people that I have been working with one-on-one. And 59% of all the plans that are offered under these Medicare Advantage plan are HMO. And these plans will cherry pick. They will decide, it's so interesting, they will make plans available to people in certain zip codes. So I did this sort of analysis of Upper Northwest. So you see put in there Palisades and Georgetown and Wesley Heights and anybody else kind of in upper Northwest of 2007 or 2016 zip code. And then you look at Benning Road and some of the places over in Northeast, and there is a disproportionate number of the HMOs that are offered in those lower income zip codes. So in a zip code of, I don't know off the top of my head, didn't memorize it, but let's say over somewhere in Northeast, if you were to look at the plans, all the plans that are available, probably 6 out of 8 of the plans that would be available would be HMOs. And the absolute reverse of that is true in upper Northwest. If they offered 8 plans, the likelihood would be that 6 of them are PPOs and 2 of them are HMOs. So that's sort of a wake-up call that more lucrative plans are offered in higher zip codes. And I'm sure it's not against the law, but it's just very telling. So let's talk about what happens if you sign up for a Medicare Advantage plan and you want to switch. There is a lot of latitude. I think the amount of latitude that's available is actually, I think, telling that people hear the bells and whistles and see, wow, these are great plans. But Medicare gives you a lot of time in which to switch out of them. And so you could, let's say you signed up, you were first enrolled in this, let's say you were enrolled in June for your very first time, and you signed up for one of these plans and you're like, oh, I really hate this. This is really awful. So Medicare allows you through 3 different enrollment periods of time to either switch out of a Medicare Advantage plan altogether, or put yourself in an original Medicare, or maybe find a different Medicare Advantage plan. And the caveat to all of this, though, is if you're getting out altogether and switching over to a Medigap plan, you need to make sure you remember to buy a drug. That doesn't come. Most of these do have drug coverage in them, so you want to be sure that you remember that you need to get a drug plan if you decide to drop out of your Medicare Advantage plan. Let's talk about the Medigap plans. These are confusing to people, and I think the operative word is gap and supplement. So essentially, they supplement what Medicare doesn't cover. So as we said, Part B pays 80% of all outpatient expenses. Well, how are you going to pay for the other 20%? So that's why people will buy these plans. And they're sold on the open market. And just keep in mind, these are private companies. They're not healthcare providers. They're insurance providers. So they're not covered by the healthcare industry. They're covered by the insurance industry. But they do have to be approved by Medicare, even though they're sold by private insurance. Sometimes people are a little confused by this because they'll look at the Medigap plans and they'll find the lowest premium without realizing that that probably comes with a high deductible. So in some respects, there are people who would choose a plan that had a lower premium because maybe their monthly income was less, but maybe they had a fair amount of money in the bank and they could absorb a higher deductible if they needed to use the service. One of the really important coverages that they offer by having a Medigap plan is the coverage that you would get in a skilled nursing rehab facility as long as you continue to qualify for a skilled level of nursing. So Medicare would pay day 1 through day 20 full. Medicare day 21 through 100, Medicare would pay all but $200. And $200 would be then paid for through your Medigap or supplemental plan. And the caveat to all of that, if any of you have ever sat through the observation status lecture that I did, you have to have had a 3-day qualifying stay and an inpatient in the hospital. And the other thing about this, it's so misleading, is people see these numbers and they make an assumption because they hear and see Medicare pays for 100 days in a skilled nursing facility. And in point of fact, that is, you could count on the head of a pin the number of people who actually get a full 100 days coverage. But in theory, and so whatever amount of time you're covered, this is how it breaks down. Day 1 through day 20, you pay nothing. Medicare pays it all. and the supplemental plan then pays the co-insurance. So assuming you're still getting the skilled care. And the other thing with these plans that when I've worked one-on-one with people, help them figure out, it's Plan G is probably now has become the most popular of these plans. And it is because it has the most robust service. And it also affords people emergency foreign travel coverage. So if people spend a lot of time abroad, I also really encourage people to get health travel policies because this pays for emergency. Like if you fall and fracture your hip and you're touring around Italy, it'll pay for the ambulance, it'll pay for the emergency room. But if you needed to be hospitalized, it would not. But at least you have a baseline coverage here when you have a Medigap plan. So here's what is really difficult. This is just a really difficult situation. People, when you first buy these plans, failing to buy one when you're first eligible can be like the death knell, basically. I'm exaggerating, obviously. But I have known a number of people who have said, I'm not sick, I'm not going to buy one of these, I don't need it, I have Medicare A and B. Well, unbeknownst to most people, the enrollment in Part B triggers what's called your one-time open enrollment, your initial open enrollment period. And that's the window in which you can get one of these Medigap or supplement plans with no health questions asked. It's called the Medigap open enrollment period. And it's 3 months before your birthday, 3 months after your birthday, or when you lose your employee coverage. Anything after that time, if you wait for any reason, there is what's called medical underwriting. And that's the process by which the insurance company will come in and they will assess, do they want to take a risk and offer you insurance? And what's confusing for some people is when you think about the Affordable Care Act, and one of the things about the Affordable Care Act that made it such a wonderful program was that you could not get denied based on pre-existing conditions. Well, these plans, much like the Medicare Advantage plans, are governed by the insurance industry, not by healthcare industry. These are private companies, and that doesn't apply to them. So if you don't sign up when you're very first eligible to do it, you may not get it at all, but you certainly are going to pay more. The other thing that happens here is, and some of this comes down to just, sort of almost a Hail Mary moment where you say, and my premiums have gone up year after year after year. So should I get a new plan? Well, that's not a yes or no question. That's one, A, can you get it? B, can I afford the new plan? Because there's no way to guarantee that you would get something at the same rate. So think about, I'm assuming you're all in here and we're all the same age, give or take. The kind of things that happen as we age, like we may have diabetes or hypertension or cancer or COPD or anything. Any one of those conditions, which we don't necessarily think are just that aberrant, any one of those can result in a denial of getting coverage. So in a nutshell, if you don't apply when you're very first eligible, that's when you first apply for Medicare B, it's going to result in higher costs. You will be subject to underwriting, and you likely will not find a company that will sell you a plan. So here's the other thing that I think absolutely nobody knows. So this is my contribution to Palisades Village for the week. When you look at these Medigap plans, what you see is people look at premiums and copay and deductibles, and you can look, go on the Medicare.gov website and just tool around a little bit. But each of these plans has another whole layer to it that most people are not aware of. There are 3 types of pricing for these Medigap plans. One is called community rated. And that's the one you would most like to have, but it's the same premium for everybody, regardless of what your age is when you first sign up. Then there is Attained Age, and that's the pricing that's lower for people when they first enroll, regardless of your age, but it's lower for people when you first enroll, but it gets more expensive over time. And then there's one that's called issue age related. And that is the premiums are based upon the age you are when you buy the policy. So let's say you're somebody who turns 65 and retires at 65 versus somebody who stays in the workforce and doesn't retire till 67. 65-year-old person is going to get the better price on these plans. But because they go up as you get older, they get more expensive. So let's look at where you find it. And again, I'm sorry, this is a screenshot, so you may not be able to see it very well, but these are just two examples. And again, there's so much to take in when you're trying to find a plan that these get overlooked really easily. But this AARP plan, the United Healthcare, if you look on the right-hand side, community pricing, that's the premiums are the same no matter how old you are. The premiums might go up, but it's only based on inflation, not on anything else. Versus this Bankers Life policy, which is Attained Age. So that means the premiums are lower for younger buyers, but they go up as you get older, and they can eventually become the most expensive of the Medigap plans. So this is a real-time issue for so many people. And one mistake number 10 is selecting a provider who's either non-participating or considered opt-out. So healthcare providers, be they physicians, physical therapists, nurse practitioners, they have the option of participating in Medicare or not. And there are three categories of providers. There are what the participating, which is kind of the common or has always been the common type of provider. And that is, let's be very generic. You go to your doctor, you hand them your Medicare card, you hand them their Medigap card. They accept Medicare as the payment in full or accept your Medicare Advantage plan as payment in full if they're in the network. That's it. You pay your $15 copay or whatever your copay is, and that's it. Well, there's another category that a lot of people don't really know about called non-participating. And I would tell you that Medicare is the slowest payer at the lowest rate with the most amount of paperwork that there is of virtually any type of insurance known to humankind. So there are a whole bunch of providers that are just saying, no, we're going to be non-participating. What that means is that you pay out of pocket for the visit, and they can bill you an additional 15% over what Medicare would pay them to make up the difference. And it can go one of two ways. Either they can submit the billing sheet with the CPT codes, they can send it to Medicare on your behalf and you get reimbursed, or they hand you the bill with the CPT codes on it and you submit it to Medicare and you get the money back. Most of you have heard about the concierge practices. Those are a lot of doctors in private practice who are just saying, we're drowning. We cannot absorb the cost of doing business with all these Medicare patients because Medicare pays us so little and requires so much of us and is so low to reimburse us. So they go with this concierge model, which you pay, somewhere about $1,500 or $2,000 a year just to participate. And so most of them have become the non-participating. And as long as you pay them and then you can get reimbursed from Medicare. The final category, which is becoming increasingly common for physical therapists and occupational therapists and social workers, is that they opt out altogether. They're not taking Medicare, period. And most of them not taking any kind of insurance, but they're sure not taking Medicare. This is kind of interesting in real time because I did this talk last week for the Iona Around Town program. And my email is at the end, but on the last screen here. So somebody emailed me and basically scanned a letter that they had just gotten from their dermatologist, that dear Miss So-and-so, beginning December 1st, I will no longer be involved with Medicare. I am opting out of Medicare. And it explained in the paragraph that if they chose to stay with their practice, that the patient, this person, would pay 100% of whatever the costs were. And in addition, you basically sign a contract with Medicare that says, I know that I'm opting out, it's full knowledge, full disclosure, and that I will not try on my own to submit the bills to Medicare. So it's kind of ironic that this person had just gotten this last week and then, scanned it and emailed it to me. And that's because, again, the reimbursement, particularly where I have seen it most, and this is just based on personal experience, what I have seen it most are physical therapists. And let's say I have in the past gotten PT at Georgetown. There are a substantial number of people who leave hospital practices and go out on their own and charge $200 a session, and they are opt out. They take no insurance at all. Psychologists and social workers similarly, because if you think Medicare reimbursement for doctors is low, Medicare reimbursement for psychologists and social workers is just abominable. So 99% of all the people in the sort of the mental health field, none of them will take. I mean, it's a rare person that you could find that will take Medicare. So, okay, drug plan, opting out of a drug plan. This Medicare D technically is voluntary. You don't have to sign up for it. It's not like A and B, which you're suicidal if you don't sign up for A and B. But D is voluntary, and they offer it to everybody. But if you decide not to join a Medicare drug plan when you're first eligible, remember back, first eligible, age 65, 3 months before, 3 months after. Or if you're leaving the workplace where you've had employer coverage, they call it credible coverage. Only Medicare could make that word up, and spell check doesn't like it, but that's what it's called, credible. If you don't enroll when you're first eligible to do so, there is a late enrollment penalty that grows over time. So the longer you are without a drug plan, the more you're going to pay if you end up joining a plan. And this is even more complicated than the B one, because for each month you're not enrolled, your penalty grows by 1% of the national base drug plan premium, which increases every year. So most people have seen every year, if you have it, Part D premium goes up. And this is 1% of whatever the national base rate premium is. So let's look at it in real time. So you don't have to pay a penalty if you first sign up. But when you don't, or if you don't, you pay 1% for each month. That's 12% a year. If you don't join when you're first eligible, or you go for 63 or more days without credible coverage. Now, in my heart of hearts, I cannot imagine where 63 days equates to, but nonetheless, it's 63 days. In addition to a drug plan penalty and premium, Part D has a similar surcharge to Part B. Do you remember we looked at the next to the last right-hand column where your Part B premium went up based upon that income-related amount? Part D has a similar surcharge. So if you're in one of those higher income tiers, you're paying Part D premium, assuming you aren't paying a penalty, but let's assume normally you're paying whatever your Part D premium is, and you're going to pay a higher amount if you're in any of those over income categories. So imagine you marry together a ding, you get a ding because it's a 12% if you haven't signed up. Then you get a ding because you have to pay more money because you're paying a service charge. So half of my screen is cut off here, so I'm just going to walk through as best I can see. If you waited 14 months after you were eligible for Medicare to join a plan and you didn't have coverage, you're going to pay that late enrollment penalty of 1% a month in addition to your premiums. So the math on this is the penalty is based on the national base. So every year that changes, but in 2023, it's going to be $32.74. And that changes each year. So your premium is going to be, if you look at the bottom of the screen, you'll pay $32.74. That's the base premium times 14 months, when you 14% because you didn't roll for 14 months. So there's an extra $4.60 added onto there. And so that increases your monthly premium, plus which, if you're in the higher income category, it adds even to that too. So going without Part D, even though it's technically voluntary, can be extraordinarily expensive. This is a big one, and this is right now I'm on this soapbox because even as I walked the dog this morning, I ran into one of my neighbors. He said, well, what are you doing? Are you doing any training for Palisades Village? I said, yeah, actually in about an hour and a half. And I said, have you checked your drug plan this year? This enrolling in, let's assume you have a drug. In the biggest mistake that anybody can make in real time is not taking the time to look at their drug plan during open enrollment season. I know it's a pain because it takes time and you go on the Medicare.gov website and you're looking around, but I would tell you that there are so many things that can change over which you have no control. And so now is the time, the October 15th to December 7th, because what happens is drug companies can change their formularies, and that's the list of approved medications. And they can do that any time of the year with a 60-day notice. And this includes either not covering the drugs or putting it at a higher tier, which means you pay more out of pocket for your copay. You, however, cannot change to a new prescription plan until the next open enrollment period. So let's say things look good and you've gone along and you haven't noticed any changes. Well, you can get a letter in the mail that says, you know, your tier 2 drug is now going to be considered a tier 4 drug. So let's talk about what you could do for that, because I think there are several things potentially that you could do. One is the doctor, whoever prescribed for you, the nurse practitioner, they can file with Medicare asking for a lower drug plan if it's been, a lower copay if the drug has been moved to a higher tier. But that requires paperwork. And you know that physicians don't have a lot of extra time, and so they may or may not be willing to do that with you. But a couple of other options that you have, you can file an appeal, and that too is a paper process that takes a fair amount of time, and you write your letter and the physician writes their letter and you marry them together and you send the appeal. You could ask your doctor for a different drug. That's not always possible. I worked with someone about 2 years ago who was on the blood thinner of Eliquis, and at the time it was a fairly new drug. And that doctor said, absolutely not. I'm not going to put you on Coumadin. That was like the original drug, blood thinner. And they said, no, you need this Eliquis. And so the person ended up paying for it out of pocket, which was prohibitively expensive. If there is not a different drug, then what you can do is look at the drug companies, because many of them have these programs that they offer that will subsidize the cost of a drug. And anyone who watches any commercial TV has probably seen the AstraZeneca may be able to help you commercial. And these new drugs, Ozempic, I think, is the one that's the psoriasis drug. A neighbor of mine, the first shot of that drug was $14,000.
Jeez.
So trying to negotiate that is really important. And you probably can't, some of these cancer drugs, they're mind-bogglingly expensive. I mean, just beyond your comprehension. And so when I beat the drum and tell people that they should get a drug plan regardless, my advice to people is, even if you take nothing, if you take absolutely no drugs at all, find the least expensive drug plan that you could find and enroll. It's in my mind, it's a lot like buying car insurance or homeowners insurance. You may never wreck your car and may never need it, or your house may never burn down or your roof collapse in a hurricane, but you have insurance and you need it. So it's better to pay, you know what, $22 a month and have coverage, because when you get into these new high profile drugs, I mean, it's incredible. The other alternative, and I think there are several of you who are on here who probably already know about Goodrx, but I feel like I'm a spokeswoman for Goodrx because it's like the best thing you could possibly imagine. What it is, and I put a slide in here specifically, and I'm not sure how much you can see it, so I screenshotted this. But what Goodrx is basically, and it's, oh, oops, there's a typo in there. It's www.goodrx.com, not a comma. Sorry, that was like a midnight inclusion last night, so forgive the typo. But what Goodrx is you would go in on this website and you would type in the name of your drug, the frequency with which you took that drug, and then it gives you a list of pharmacies that you could, any of which you could use. And what it does is it tells you how much this drug would cost at pharmacy X. So in this case, losartan is a really low dose. It's a really, really basic high blood pressure drug. So in this case, 25 milligrams is the least. So it's a Safeway is where you normally would go. So you know that if you go to Safeway with your prescription, you would pay $10.76 for a 30-day supply of 25 milligram losartan. If there is a downside to Goodrx, the downside is that you have to have a written prescription the first time you get it filled. So you would go, you print this out. Well, I know a lot of people don't have printers. They now have a way to do it on your phone. There's an app on your phone that you can show at the pharmacy, but you do have to have a written prescription. And most doctors now send things through electronically. So that does add a layer of, a little layer of hassle to it, but you get a written prescription. You either print this or you put it on your phone. And then you go to the pharmacy and you show them this and you give them prescription, you show the cost or give them your form, and they basically put it in their system. So every other time subsequently that you go back for a refill, even if it's a new prescription, I mean, that same prescription, but it's been renewed, you will continue to get the Goodrx price. For those of us who have animals who are on drugs, and my dog is on drugs, you can get prescriptions for anything, for dogs, for cats, for birds, for anything on here that, and anyone who owns an animal knows how much these drugs cost if you get them from the veterinarian. So I say that because it actually is a money saver. In fact, well, at least one person who's on the call, I showed this to them because they didn't believe me, but my dog Coco now has her own Goodrx card. They send it to me in the mail. She takes anti-anxiety drugs and sedatives. And so she got a card in the mail that it said it was Coco Goodrx card. Anyhow, the last alternative would be that you'd pay the full price of the drug. So I'm going to take a breath and be done. Should we take questions at this point? Anne or Erica, if you're managing the chat room, I don't.
Yeah.
I'll stop sharing. And you will send a copy of these. You'll send these out electronically to people, right? Because there probably a zillion questions, but there's my email address. I set up a private practice when I retired. I retired as a director for all the aging services from the city of Alexandria. And I had had a bazillion years of healthcare and hospital and home care experience before that. So one of the things that just I learned through my career is how many people don't understand Medicare. So I set up a private practice so I could work one-on-one with people if they needed help. And I'm seeing more and more people who are staying in the workplace and want to come back and say, okay, what do we do now? How do we never paid attention to this before because we didn't need it? Or people who are saying, like, I'm in the wrong drug plan. Can you help me find something? And then do training as today as a volunteer. So I guess this is called sharing the wealth.
We are so appreciative of you sharing your wealth, because your wealth of knowledge is impressive. There was a question about early on in your discussion, you were talking about having to go physically to an appointment, and if you have an elderly parent, what happens if you can't do that?
I'm sorry, give me a context for the question again.
It was early on, you were talking about having to physically go to an appointment to do something.
Yeah, hi, it was me that asked the
Okay.
question. I'm trying to remember what the context was, but you had described needing to go down to, you said during COVID, they were taking online.
Oh, that Social Security Administration, you mean for going back and looking at modified adjusted gross income? Is that what you?
Yes.
Okay. To the best of my knowledge, they are now requiring you once again to go in person.
Mhm.
I don't know if exceptions can be made. I mean, prior to COVID, you would basically download a form on the Social Security Administration called the life-changing event form. And then you would set up an appointment with Social Security, you would go down there and they would decide yes or no. They would give you a time frame in which they would say, okay, yes, I see, legit, your income is lower now in 2022 than it was when you were still working in 2018, and then they grant it. During COVID, they were doing everything online, including like late enrollment, just everything was online. I think they're back in person now. So you still need to have an appointment, but it's worth, the one thing about Social Security is, you can't get through on the phone, and you can't, it's really hard. It's really hard to find. Actually, what's interesting is that it's really hard to find a Social Security office. There used to be one at M and 21st. You could take the D6 bus and it would drop you off right in front. That's been closed for several years, actually, even pre-pandemic. But I don't know if they're requiring an in-person visit now. I think because of the consequences and the veracity of saying, yes, indeed, my income really has gone down. That's one of the reasons that they were requiring in person. Whether they are still or not, I don't know, but they've opened up some other things. So I suspect it still might be, but you'd be able to find out from Social Security if you called. The one thing I know about them is they'll say to you after 400 times of saying, the line is busy or whatever they say, we'll call you back. They actually do call you back. So it's usually within the same day. So it's probably worth a phone call to find out how you go about doing it post-COVID, if they still require you to be on.
Okay, so my situation is that I'm got power of attorney for my mom who's not able to move much. So did you have experience pre-COVID that if power of attorney came down and had the appointment, that was sufficient as long as the paperwork showed that?
Boy, that's a really good question. I have not.
Okay.
I don't know. So I think that would be, you probably need to get on the phone and ask them. It would be unfortunate if you had to, because Social Security offices are pretty few and far between these days, but I
Right.
think you're gonna have to endure the whole time and just give a call and ask.
Okay, thank you.
Looks like there's 11 in the chat. It's 11 questions in the chat room. So should we go there?
Well, that's what I started with the first one, and a couple were postings of the articles you referred to. Next is Ray, Part D, AARP supplemental with UHC. Have been paying monthly for UHC Part D, but finding that paying out of pocket with single care or similar is often less expensive than co-pays with deductible, etc. Is it safe to do away with Part D in this case? I would hate to have Medicare not cover drugs.
I think the only way that you are safely able to not have a separate Part D plan is if you have a Medicare Advantage plan with drug coverage. Do not give up drug coverage. And I'm not sure exactly what you said. You have AARP, United Healthcare. Is it a Medicare Advantage plan? And how do you get the drugs paid for? So I'm going to answer a question with a question because I don't know that specific plan.
Okay.
Can the person who asked it ask me again? Or do you want to read it again, Erica? Maybe that would be helpful.
Okay. Regarding Part D, AARP supplemental with UHC. Have been paying monthly for UHC Part D, but finding that paying out of pocket with single care or similar is often less expensive than the co-pays with deductible, et cetera.
Well, you
Is it
don't
based-
have to drop the coverage. Is single pay like Goodrx? Is that a similar discount program?
I don't know.
Because it
Yeah,
sounds like it.
It's like Goodrx. I'm sorry, I just am jumping in here. This is not with a Medicare Advantage plan. This is directly through the Medicare supplement plan with AARP. And
And-
there's a couple $100, I think, deductible for the year. And then I find that the copay for the drugs is sometimes 4 to 5 times more expensive than just paying for them out of pocket.
Okay, okay.
And the premiums are close to $30 a month. So I just started wondering why I was carrying that insurance, but I would not dare let it drop unless I were absolutely certain that it would be safe. And I don't feel safe dropping it, but I just thought I'd ask the question because
Well-
it seems so ironic. There's no logic to what you end up paying for drugs these days at all.
No, there's no logic. And I think the original platform for Goodrx, and probably, I don't know, the one you mentioned, did you call it single care? Is that what you called it?
Yes, I couldn't think of Goodrx, but that's what I've been using. I've been using Goodrx along with a Kroger plan that costs me something like $25 a year. Through
Okay.
Iris Teeter.
Well, and interestingly enough, that is the platform upon which Goodrx was basically evolved from the very beginning. They would bill themselves as we're cheaper than your copay.
Mhm.
So essentially, you're keeping $30 a month worth of a D coverage with your AARP United Healthcare coverage. So you're keeping that. But
Yes.
what you're doing with GoodRx is you're going to look, or whatever other of the discount programs, you're going to look and say, you basically look both what new drug, old drug, how much would I pay if I paid out of pocket with GoodRx, and how much would I pay if I use the insurance plan, the Part D plan?
Yes, and that's the, I guess what you have to do is calculate all the time, because if you do use the minute you use the insurance for the copay, you are slapped with the deductible for the year, which comes to over, I think, a couple $100. Whereas if you don't use your insurance at all, you're never charged that. And you
Yes.
can get a lot of drugs at $20 for 3 months worth for the same thing. So it's just one of these things. I guess you just have to try to be smarter than the whatever logarithm it is that figures these things out, which is not logical at all.
No, it's not, but it's a good tip to share with your friends,
Yes.
because you're
yes.
right about meeting the deductible for the year, and that's probably the one, if there is a downside, none of what you're paying out of pocket for GoodRx or any of the other discounts gets counted towards your deductible. So it's kind of like an all or nothing if you had to use it, but Medicare, yeah, I mean, you're looking for the deductible plan, you pay X, they count that X, but these out-of-pocket expenses don't. So if you can stay out of altogether, then bravo. But just don't drop your drug plan.
And then, well, that's great. Thank you. I appreciate that. I was thinking that's what I would do, but it's great to have an expert concur. Thank you.
You're welcome.
We've got one last question.
I'm sorry, can I just jump in here on a follow-up for that? I just want to clarify that discussion, bottom line is, don't drop your drug plan, but sometimes it is better not to use it and use RX or Harris Teeter or Kroger or something else. Is that what you said?
Yes.
Okay, thank you.
Think about your drug plan as your car insurance or your homeowner's insurance. You may never need it, but God forbid, if you don't have it, and suddenly you have cancer and you need chemo or you need a heart transplant, whatever. Yes.
I hear
Okay.
you, and I wouldn't, but I just needed to clarify that instead of using this drug plan, there's an alternative with this RX or other systems.
Yes.
Very good.
Or there can be. I mean, there may be times when it is cheaper. What was I looking at? Something for somebody recently, and it actually wasn't cheaper. It was not cheaper on GoodRx than it was for the copay. But again, it's a matter of the arithmetic of it all, and it's a matter of just doing a little of your own study. But by all means, don't. I would like hold up a big banner and walk up and down, M Street and say, sign up for Part D and keep your drug plan. But obviously, I'm gonna get off my soapbox now. But
Okay, last question. If my spouse and I are turning 65 next year, but he will continue to work and we have coverage through his employer, do we need to sign up for any Medicare coverage yet, or do we wait until he retires?
you would wait until he retires and you no longer have employer coverage. And if you remember one of the earlier slides, there were 4 categories of enrollment periods. So that would be called a special enrollment period. You have 8 months from the time you lose your employer coverage to sign up for Part A and B. I mean, there's no reason not to sign up for A because it doesn't cost anything and you can. And some employers, really interestingly enough, some employers require people to sign up for Part A, but that's an internal employer decision. They require them to sign up for A because A serves as the hospital insurance. So the employee coverage, the employer share of the coverage is less if they can offload any hospital expenses to Medicare because somebody has A. But not all companies are like that. So if it's not required, you don't have to do it. But the point at which the person's husband retires, then neither of them are having employee coverage anymore. Then you would begin the process of applying. You have 8 months in which to apply. Why you'd wait that long, I don't know. But then you have, interestingly enough, though, you have to apply for a drug plan. Remember back there, the 63 days, I think actually that's where it came from, because you only have 2 months in which to apply for Part D after you no longer have the credible coverage. And when that time comes, then you basically, there's forms that you fill out that your human resource department fills out for you as you're applying for A and B. And you're basically attesting to the fact that you had credible employee coverage with drug coverage. And then that both of them were credible and met the requirements. And then you sign up completely without penalty if you check all those boxes and do all those things. One thing that I need to say, and this, I personally only learned this a couple of years ago. Sometimes when people leave their employers, they go on Cobra. Cobra is not inexpensive by any means. But interestingly enough, Medicare does not consider Cobra as credible coverage. So if you stay on Cobra for 18 months without knowing that it's not credible coverage, and then you go to apply for A and B and a drug plan because you're no longer on Cobra, you get dinged for the rest of your life that Part B penalty and the Part D penalty for late enrollment because Cobra is not considered to be credible coverage. And so few people know that, and most employers, I don't think, know it, or they wouldn't really, I mean, they would encourage you to get on Medicare as opposed to get on Cobra.
That's crazy. MaryAnn, this has been amazing. Amazing,
Thank you.
amazing. I can't tell you, the chat room agrees with me.
So should I look at the chat and get some kudos here? Is that what the plan is, right?
I want
Well,
to
it's
just,
been a pleasure. I hope it's helpful, and I'll convert these to PDF, and then you can go ahead if you want to go ahead and send them out to people who have been on the call. There's a lot to absorb. I mean, it's a lot to absorb in an hour. It's a lot to absorb in a lifetime, I think. So,
Thank you very much, MaryAnn.
well,
We have,
very well.
Sandy has her hand up.
I
Okay,
just wanted to clarify that the slides will be coming out to us.
yes,
Okay, that's good, because there wasn't, I mean, there was so much information, but it's nice to be able to go back and review it.
yes, yes,
Yeah,
I'm assuming they'll be attached to an email soon.
yes.
Thank you.
You're welcome. Anybody
thank you,
else?
MaryAnn. That was
Thank
just
you,
excellent.
Maria. You're
Well, what
welcome,
a-
Bob.
What a
Nice to-
terrible damn system it is, really. I mean,
Yeah. Well, Bob's from the UK, and if you hadn't heard his accent, it's a lot, is it different? It's just different there, isn't it? I mean, it's not a,
well, we've had the National Health Service since 1948, and it's worked very well. It's currently suffering because of lack of investment, but nobody goes broke by being sick in the UK or most of Europe. I mean, this is well known by all of you. I'm sure that the only answer really is to get the insurance companies out of the way. Sorry, MaryAnn, but and have a
I
single,
don't work for an insurance company. so you
no,
don't
and have a
apologize
single payer
to me.
system. Why don't we have that? You know,
Absolutely.
Yes,
and I think everybody on this call would absolutely agree with that. It's just all
Yes.
these machinations you got to go through. It's just terrible. But you've been so helpful, MaryAnn.
yes.
Well, I have
in
to share a thought.
demystifying. In
Do you
demystifying
remember
a lot.
when Bernie Sanders was running
Oh, yeah.
for president, and his mantra was Medicare for all?
Yeah.
I couldn't help think about, this guy has never been on Medicare. He could not possibly advocate
Yeah.
that was this convoluted for all. It's like, are
I
you
think you're right. That was a bad analogy. It was bad.
like, really?
It should be like Canada for all or something like that. You know?
Yeah.
Or
Mary-
Germany for all.
MaryAnn, are you in DC or in Alexandria?
I'm in DC. I live in DC.
Okay.
I'm a Palisades Village member.
I see.
And we are
Okay.
most fortunate to have you. Thank you
And
again.
well done, MaryAnn. That was
Yeah,
just excellent.
thanks again.
Thank you much, and we'll get the slides out to you.
Very grateful.
Okay, thank you.
Anyway, thanks for
Thank you.
coming.
Cheers. Bye-bye.